just mentioned, progress needed to continue and was also already in need of acceleration to reach those further left behind. And now COVID hit us, and it has had many implications for health and well-being. There's been direct consequences from the disease of COVID, and then we've also seen healthcare disruptions that could reverse decades of improvements. Many people have not had access to healthcare for managing their chronic diseases. There has been disruption in childhood immunization programs, and this has been reported in around 70 countries. Children have been kept out of schools, and we are seeing more and more the role of the school sector in how it determines the health and well-being of our children and of us adults as well as part of the society. Women are disproportionately disadvantaged economically, and they are also being more exposed to violence and their perpetrators, and less access to services for survivors. And overall, we're preparing for the worst economic recession since the Great Depression. This is a problem because our current models of development have been focusing on the health of the economy and not on the health of the planet and the health of our people. But we know that even though we have a dark scenario in terms of economic growth. Hello, sorry. Someone is speaking. Could you please mute yourself? Thank you. We know that this is the current model, but we know also that even with this recession that we are foreseeing, there are resources and we know what to do in order to continue making progress. This is probably the outside where you were standing, Lorna, waiting for all the SDGs to be signed 5 years ago. This was adopted in 2015 by representatives of all countries at the United Nations Summit in New York. The 2030 Agenda shows the commitment of world leaders to generate a plan for action for people, planet, prosperity, peace, and partnership. And the different figures that we've seen that have been shared millions and millions of times around the world show how integrated the agenda is. We also know that this plan had an unprecedented scope. All sectors are involved. All its goals and targets are integrated and indivisible and will not be achieved unless we leave no one behind. So these are inclusive and they are universally applicable. No country in the world has achieved sustainable development, and there's a lot of balance that still needs to happen between the richest and the poorest, within countries and between countries as well. We think of the SDG framework then like a system of cogwheels, like it is visualized here, where if one is lower, if progress is lower in one of the goals, the others will not function. And making all of them function is not an easy task and requires transformative change. Transformative change is a long-term process that combines individual, political, and societal level action at all levels. We would hope that transformation would look at something as linear like this, but actually transformation maybe looks something more like this. There's discomfort, there's shock, there's opposition, and then we face a turning point where we are ready for new values and ideas and are able to create the world we want. We believe that the pandemic offers an opportunity to develop recovery plans that build a more sustainable future. And for this, in the European region, we have been working for many years with academics, civil society, countries, colleagues, and we have been trying to figure out a framework that will facilitate this transformative change and address all of these challenges. We call this the E4A approach: engage, assess, align, accelerate, and account. And they all serve as building blocks composed of policies, processes, activities, interventions that all operate in a continuous and synchronous action. Based on this approach, I can tell you that there's been progress. We have seen countries, regions, and cities preparing and planning in the long term in order to make progress and also to be prepared in terms when crisis hits. Member states have already prioritized implementation of the 2030 Agenda for Sustainable Development, and they have made efforts to integrate the SDGs into relevant planning frameworks. This integration is not easy. The fact that all the SDGs covered so many different areas and they're universal, this also is a challenge because countries may think, or people may still try to cherry pick and choose that thing that they're already doing and name it now in the name of sustainable development. But we also have seen that this integration has been facilitated through the creation or adaptation of institutional arrangements where there's high level political commitment. And then there's also a lot of actors involved in charge of promoting horizontal coherence across ministries, sectors, and levels of government. The health and well-being sector has been either highly or moderately involved in these institutional arrangements. And they have engaged with key stakeholders, recognizing that the engagement of all sectors of society is important for effective leadership. This we know because we have been in conversations with countries and we have taken some steps also in trying to ask them what are they doing and what are the lessons they have learned and how this can be also then shared with other countries as they also keep on making efforts. I would like to touch a little bit on Align, because this is one of the biggest areas as well that we can probably have some influence. And we as global health actors and also local actors can have some influence, and it's important to know. Some of the first steps towards integration of the SDGs into relevant planning frameworks require an overall understanding of the development process where we are. And it is not only to look at things in an aggregate level, but we also need to look at this at how we are doing in the disaggregated level, across different populations, across different countries, across different regions and rural, urban areas. Gender differences are necessary to be identified as well. And all of this helps us also identify what are the development priorities, the needs, institutions, who are the actors, what resources we have at hand, and any other factor that will influence effective implementation. To date, 142 countries have presented already a voluntary national review since 2016. These reviews are presented by government representatives to other peers at the high-level political forum for sustainable development. And they are based on mechanisms at the national level. And some of them have also mentioned how they have engaged with the subnational level, cities. And there's also efforts right now also in trying to make these processes, these voluntary national reviews, also at the cities level. These are the main global accountability mechanisms for the SDGs. The development of comprehensive plans involving a comprehensive range of stakeholders and sectors, and that have focused on improving population health and its determinant, with the engagement of the health sector, can support shared values, just as the SDGs do that as well. They can foster synergy, they promote transparency and accountability for developing health and well-being. So the fact that these plans exist in most countries makes us feel that we know where we're going. And with 90% of these plans have already prioritized health and well-being and recognize that without health, there's no sustainable development. This is great progress, and more we see more leadership for health and well-being. But more needs to be done. Progress is dependent upon the process of implementation, and we know that we need to ensure that those intentions in their plans are turned into results. Most countries have already put also new governance mechanisms or adapted all governance mechanism in place to ensure that they follow the principles of the 2030 agenda of inclusivity and intersectorality. And most countries have reported engagement by civil society and local authorities, illustrating this pluralistic approach to implementation. We have to know who are the agents that can hold actors to account. We can be those agents. We have to know what are those standards to define what actors should deliver. And these are the SDGs, the human rights mechanisms, laws, regulations. We have to also know who are the actors responsible for implementation. And another thing that really helps is having the right mechanisms and tools for accountability. In this next slide, I want to show you some of the examples of the mechanisms that in general have been put in place around the world and that can also help ensuring that progress is made. Groups such as the Coalition 2030, for example, in Ireland, which the Irish Global Health Network is part of, are important platforms where we can participate both as beneficiaries, but also as agents that can hold actors and governments to account. Remember that the actors are not only government, they're also private sector. They're civil society organizations that must be accountable also to their constituencies. Some of these groups and us as well as individuals can work with government institutions. There are designated government SDG bodies and ministries. There are national budgets or public finance systems. There are parliamentarians, and we can support mobilizing parliamentarians to ensure that implementation is done. And we can also engage with local authorities. There are certain formal processes as well that can be used, voluntary national reviews, as I mentioned, and some of these are done at the national, subnational, and city level. And there's been many different activities in countries where they have tried to engage, making laboratories for the voluntary national reviews, trying to engage all population and civil society. There are international human rights mechanisms, government consultation, legally binding health treaties, reform, strategic litigation, legal empowerment, and those are all formal processes that can be used to hold accountability. There's also informal processes, and we must not forget about these because that's why it's so important to engage with the media, to raise awareness, to connect with people from around the world. And this is such a huge opportunity that you are giving us here. And we also know that there's different approaches to accountability. Lastly, before I leave you, I would like to show a video that we prepare in the regional office as a way of engaging as well in the future we want.
Emilia, I think you need to share your sound.
You cannot hear the sound, you said?
No sound.
Yes, we can't hear the sound.
Yes, you can. Okay.
No, we can't hear it. Sorry, we can't hear it. Stop sharing and please share again and click share the sound, the device sound. Thank you.
Yeah.
This looks like a child who's eager to go outside. This looks like a child playing hide and seek. This looks like a child who wants to save her teddy bear's life. Except it's not. By 2030, these children will be teenagers. Their health will be influenced by so many factors. They deserve to live in a healthier world where air pollution, child abuse, and deadly diseases are bad dreams, not daily realities. Help build a better future for all of us.
Thank you so much. Over to you, Lorna.
Thank you, Emilia, and thank you for sharing that powerful video at the end. I was really struck by your talk there. I think it gives so much hope in so many ways to see just how many processes are already underway to implement the SDGs. What's really struck me watching your presentation, I think probably everybody, is that slide on the reversals and the disruption that COVID is causing. And I know that tomorrow there's going to be a panel discussion specifically addressing that, but it truly is shocking when you see the kind of wider ramifications of that. So before we have questions to Emilia, we're going to have all the questions together after the panel. So it's a great pleasure to me to introduce our three panelists. If Hala could put up the slide of the panels, thank you. So our first panelist is Nick Watts. Nick's a medical doctor by training. He's the executive director of the Lancet Countdown, tracking progress on health and climate change, which I'm sure many of you are familiar with. He's also the chair of the NHS England's Net Zero Network, leading an expert panel and analytical team to determine how and by when the NHS can reach net zero. He works to engage public health professionals on the links between climate change and public health, having founded both the Global Climate and Health Alliance and the UK Health Alliance on Climate Change. Nick, you're very welcome. Our next panelist will be Fran McConville. Fran is a midwife and a nurse by training, has a BSc in zoology and an MSc in health economics. Fran has worked almost all over the world, focusing on sexual, reproductive and maternal and newborn health and gender. She's a broad experience working with NGOs and UN agencies as a health advisor to the UK Department for International Development. And Fran is currently the midwifery advisor to the WHO based in Geneva. So you're also really welcome, Fran. Our third panelist will then be Suraj Rose. Suraj is a senior lecturer in the Department of Women's and Children's Health and program coordinator for the Global Health Masters at Uppsala University in Sweden. He's worked at the WHO Regional Office for Europe, where he oversaw research and evidence generation agenda of the migration and the health programme. During his tenure at the WHO, he led the production of the first ever WHO report on refugee and migrant health. So you're also very welcome, Suraj. But before we come on to the panelists, we wanted to start off with a video from Dara McNulty, who unfortunately cannot be here with us in person today. Dara, as some of you may well know, is a 16-year-old activist and author who has been taking the literary world by storm recently. Last month, he became the youngest ever recipient of the Wainwright Prize for Nature Writing. His book, which I can highly recommend, The Diary of a Young Naturalist, is a powerful account of the deep connection between nature and health from his own personal experience growing up with autism in Ireland. So we'll watch a short video now from Dara.
What matters to me is that every single person experiences a connection with nature, even if that just means walking outside for 10 minutes of their day and listening to the bird song. What really gets me angry: apathy, greed, people who are ignoring that connection to nature that we all have, and people just pushing it aside and saying that it doesn't matter. Biology, I think, was the most disappointing subject that I have ever experienced. This educational system does need to change, as well as all the other systems, because if you don't get this education in properly into my generation, how are they going to have knowledge about the natural world if you're teaching them such a boring course? I have been involved in the school strikes. It does make me really angry that the adults are coming to us for help, since it was them that put us here in the first place. And that does make me really, really angry. And we do need a system change, and not climate change, because the economic system is not, in a way, balanced so that it can help nature. It's not built for a fair society, which of course is what I also want. Allowing everybody to be equal, it's allowing everybody to have a chance at a full and glorious life. And I feel that for that to happen, the system does really need to change. I've been writing a blog for, I think it's nearly 4 years now, and I've always had the idea of compiling all of those many blog entries into a single book. Around August, a new idea came where I would write up a diary of what went on in my life for a year. The book started evolving. It centralized on mental health in connection with nature. I was really down and not very good inside. And it was nature and going up into the mornings that really helped bring me out of it. When I was actually writing the book, it was so painful to have to go back onto those memories, those still raw memories. I understood it better, and I could now see why it happened, and that has really helped me. And the book will be released in 2020, and I'm really, really looking forward to its release. Another thing that really gets me angry is just watching all these species disappear. And it's been shown time and time again how easily a species can go extinct. If you have been affected by the catastrophes that have been occurring on the natural world, which is, in all honesty, absolutely every single one of us, because not any of us can escape this, escape the disasters that are going on. All I can say to you is keep on fighting, keep on working and hard and campaigning and trying to raise support and awareness for our world, on our natural world, because I know that if we keep on trying, then we can win, and we will win.
Thanks to Dara for that powerful message to us all, and really a message to us all to really to redouble our efforts to engage with nature and to fight climate change and extinction. Nick is our first panelist, and we're going to try and do this in a more interview style, but we'll see how it works in the online world, where if we can actually find our panelists in the 180 participants. It's almost like a game we have to play. Nick, first I want to address a question to you, and it's really to kind of draw on some of the things that Dara was saying there. He clearly is a passionate voice for his generation. Hi, that's great. I can see Nick. I'm sure you all can too. Is he right to be so concerned about the current trends in relation to climate change? And how would you weigh things up at this stage, 5 years since the SDGs and the Paris Agreement?
Yeah. Yes, right. We wouldn't be here if he wasn't right to be concerned. I wouldn't have left my work as a clinician and a doctor, in Australia to work on climate change if he wasn't right to be concerned. He's absolutely right. I work for the Lancet Countdown. Our job is to gather data, to track, monitor, and to try to hold ourselves to account. And so we have what can sometimes be quite a depressing job. We track all of the different ways that climate change and environmental degradation is impacting, human health. And you see it not in 2050, not in 2100. You see it today. You see heat waves around the world today. You see the spread of chikungunya. You see dengue fever. We see the climate suitability for the transmission of these diseases shifting at present day from the baselines that we track. So there are lots and lots and lots of reasons to be very, very concerned, depressed, upset, and sad. But there's a bit of a hint in your question, I think. What's been happening just recently? Because there's been 30 years we've known about this. 30 years we've known that the health impacts of climate change, they are profound, they affect everyone, they are irreversible. But in the last 5 years, I think since the signing of the Paris Agreement, there is also reason for optimism. 7 million people around the world die every year as a result of air pollution. But in a couple of key regions, we are starting to see some really powerful shifts, and we're starting to see some improvements in air quality. And that is happening because people are paying attention to climate change, because coal is being phased out, because the United Kingdom in a couple of days, I think, is going to announce that it's going to ban the sale of the internal combustion engine by 2032. That's remarkable. That's remarkable. There are really powerful reasons for optimism. And it turns out that when you look close enough, it's because we're starting to get a better sense of exactly what he was talking about the links between nature, the environment, the changing climate, and human health.
So I think you have some slides you want to show us around the work that you've been doing in relation to I guess the work of the Lancet Countdown is gathering evidence on the broad connections between health and the climate crisis. So if you want to share some of those slides, we can look at that.
I have slides, but I also don't mind having a conversation. So however you want to do this, would you like to see some slides or not?
I think we'd like to see a few slides just to give us the overview from your side on the, I guess what's the, for those of us who are not working specifically on this area, I guess the question is, you already hinted at it, like this is huge, this area. It encompasses so many different aspects of health. So if you could you talk to us a little bit about that, and if you have any slides that show some of the interplay between global health and the climate crisis?
Sure, we can certainly talk about that. You cannot share the screen while someone else is, oh, that's interesting. Someone else is going to share the slides, are they?
Yes, I'm sharing the slides if you're happy with that.
I don't mind. Do you want me to, or do you want to do it? I don't
Yes,
mind.
I'm good here. Okay.
I prefer to do it. Okay, well, why don't you pull them up? Cool. I mean, they're a bit of a mess if we're going to skip around. But look, effectively the work that we do, it covers the links between health and climate change. It covers exactly that sort of introduction I was talking about. On the one hand, the threat to human health that climate change brings. On the other hand, the enormous, unprecedented opportunity you see from a robust response to climate change. The next slide, or maybe the slide after that, just tries to make very briefly the point, pretty crudely, that when we look closely at all of the different links, it turns out that—
I do a letter for Ethan Alexander.
Ethan Alexander. Judith, who is Ethan Alexander? It turns out that all of the different ways that climate change acts on environmental social systems. They act through the Sustainable Development Goals. They undermine the foundations of good environmental health, of good public health, good social health. The next slide shows very, very briefly just the people that come together. This is the list of the partners that make up the Lancet Countdown. It's an odd list. It brings together academics, yes, from the United Kingdom, yes, from a couple of despot places like Australia, but it also brings together the World Health Organization, the World Meteorological Organization, Mara University down in Malaysia, Tsinghua University in Beijing. We agree on basically nothing. We are academics, it's our job to disagree. We agree on basically nothing with the exception of the data that I think I'm about to show. So if we skip 2 slides ahead, firstly, we agree that we are starting to see some of those impacts on health now. We see exposures to vulnerable populations from heat wave up to present day. We see in 2018, 2019, 220 million additional vulnerable people exposed to extremes of heat. We see that trend skyrocketing as the planet starts to warm. Those extremes of heat are bad for health, but they're bad for health in some kind of surreptitious, kind of concerning ways. The impacts they have on kidneys in terms of acute kidney injury when you run into dehydration, the impact it has on labor capacity loss. We see 45 billion hours of labor capacity lost around the world because it just gets too hot outside to work. And there you are faced with a pretty difficult situation. Do you either continue to work, damaging your health further, or do you stop working, damaging your household income, and hence probably through some nutrition losses and other issues, damaging your health even more? Those impacts are concentrated, it's no surprise, in India, in Pakistan, in China, when we talk about heat, but it actually turns out that no country is immune. You see those effects the whole way through. The slides are a little bit behind, but if you skip 2 ahead, you will see that we also see these present day effects in food security. 2.9% reduction in global yield potential for maize, 3.8% for winter wheat, for soybean, for rice. This is up to present day. This is around the world. This is a pretty sophisticated aggregation we pull together to get a sense of what the climate is doing to food security. Going forward, one more looks at the vectorial capacity for the transmission of dengue fever. Now, this is dengue fever for Aedes aegypti, Aedes albopictus, the 2 vectors that carry it. You can track that through for malaria and the Anopheles mosquito. You can find it for Vibrio as well, vibriosis and the wound infections that come through. We are seeing those effects all around the world today. This isn't going to work very well, but if you skip ahead 5 or 6 slides, you will find one that says health benefits of climate action. One more. What you'll find is that when you look at all those things, God, it looks concerning. It looks really, really worrying, everything that's happening around the world. And I get pretty worried every year when we turn around. But if you go and show all of the things that a climate engineer or a climatologist would want to do to respond to climate change, and you show them to a public health professional, if you showed them here, we wouldn't say that looks like mitigation and adaptation. We would say that looks like cleaner air, healthier diets, and more physical activity, safer cities. It turns out the links that make this dangerous, that make climate change dangerous for human health, they can be reversed. We are seeing some really powerful trends. The next slide talks about trends just in air pollution across Europe. Just in 2015 to 2016, 12 months of action. And to be honest, the European Union was not even trying at that point. 2015 to 2016, the improvements in air pollution that we have seen there result in 5.2 billion euros per year. Just from that alone. And that's before they even really got started. Let's wait to see what happens in 2019 to 2020. The next slide talks about sustainable transport. It talks about the massive upsurge that we've started to see in electric vehicles. That's exciting because we know that diesel vehicles, we know that petrol is particularly bad for our health, partly because we breathe in the fumes and that damages our heart and our brains and our lungs, and partly because it means we're not walking and running and cycling when we travel. This shift that we're starting to see around the world up to present day is really quite inspiring. The very, very last slide is one thing that I'm particularly excited about, and maybe as health professionals, we might be too. Not quite the very, very last slide, I lied to you. One more. Is a tweet. It came out in January. It came out on the 25th of January. just 2 or 3 days, I think, before the World Health Organization declared a public health emergency of international concern. This is Simon Stevens. He's the chief executive of NHS England. He pulled together a task force to say, hey, I want to get to net zero because I think that the climate crisis is a health crisis, and I want to know exactly how our health service can work on figuring that out. We've been spending the last 9 months working on that, trying to figure out exactly what a net zero health service, a net zero hospital, and net zero ambulance, exactly what that looks like. There's some really exciting, really good work underway, and I think we'll have an answer sometime soon. But it's when the health profession, people like Simon, people that work in the NHS, not just in England, but across the entire country and across the entire world, when they start to wake up and pay attention to this, that's why we should get excited. Because we know that when the health profession really activates, like we have with tobacco, with HIV, with vaccinations, with smallpox, we can move mountains. Thank you.
Thanks, Nick. Unfortunately, we didn't manage to make it as much of a conversation as I'd hoped, but we can have conversation in the Q&A session. But I mean, I think that was really useful for us to see that data, because I guess we're coming from so many different fields, just to really see the breadth of the issues. And I mean, I think that the last slide that you showed was just so hopeful about the initiative to go to net zero. Do you think there's I guess it's a bit of a loaded question, especially to a health professional, but do you see a trend in the way that climate change is being tackled in terms of presenting it more as a health issue? And do you think that provides a sense of hope, in the sense that we could, does it provide avenues to address the issue that perhaps those of us who've been more on the climate side have not succeeded in reaching?
Yeah, no, we do. We absolutely do. We track social media, we track media use, we track the links between health and climate change in the UN General Assembly, in the nationally determined contributions of the UN Framework Convention on Climate Change. We look at that the whole way through, and we find over time we are seeing a pretty significant increase in the way that countries, people, companies are starting to understand the link between these two issues. The reason that's important is, I think, exactly what you pinned in on. For too long, we have understood climate change as just an environmental issue. It is an environmental crisis, absolutely, but it is also a health crisis. It is also a crisis of place. It is a crisis of gender. There are dimensions that intersect with all parts of our lives. And when we start to understand that, A, it affects every part of what goes on, we also start to understand that means we have a heck of a lot of agency. There's a lot that we can do to respond as communities. And so, yeah, I am starting to see that shift. And thanks. And then the other question, I guess, leading on a bit from what Dara, his experience, obviously he's one young man, and he has had he talks very passionately in his book about the connection between mental health, environment, and the whole climate crisis and biodiversity crisis. Is there a growing body of evidence around the interconnection between mental health and climate change? Oh, you're on mute. I am. I'm back. Those words, previously never really said at all, suddenly said by millions of people every day. You're on mute. Yes. There's a growing understanding of those links. It's no surprise that we messed that up, right? It's no surprise that initially we started to think climate change, oh, that's just malaria, right? And we missed some of the more surreptitious, silent killers, the sort of more dangerous problems. Heat is one that I'm concerned about. Malnutrition is one, but one that we should really be worried about is mental health, the effects of this change on our health and well-being. We see when there are floods in England, when there are floods in Pakistan, when there are storms in the southwest of Australia, you come back 3 months later and you take a look, you see these little spikes, these spikes of depression, these spikes of anxiety-related disorders, but you also see these spikes of schizophrenia. You see basically what happens is climate disrupts, the sort of changing climate disrupts an otherwise ordered social structure. And when you disrupt it, it turns out that some of those systems that we depended on disappear. It makes a lot of things really quite a fair bit harder. And so that is an area where It hasn't previously been recognized because we do a bit of a rubbish job as a global health community of dealing with mental health. So of course we do a rubbish job when it comes to climate change and health, but I hope that we're starting to do a better job of that.
Thank you. Thanks, Nick. We'll come back to you a bit later on, I'm sure, with other questions, and people can be thinking about what questions they want to ask Nick and put them in the chat box, because we're going to select some of those questions for the Q&A at the end of the panel. The next speaker or panelist is Fran McConnell. Fran, in your bio, you say you're passionate about the rights of women, newborns and their families to have access to quality midwifery care everywhere. And you also say that we need to start asking different questions, but you don't tell us what they are. Could you maybe start off just by saying, what do you think are the questions we need to be asking?
Oh, there are many. And I think that in the same way that Dara and Nick have raised, I think the health of women and newborns has been really focused on as a medical issue, but it contains so many other issues, the mental health, our own endocrinology, our societies, and the research tends to be very much focused. Over 80% of our research that we ask the questions about in maternal newborn health are all focused on complications, some of which are very rare. So we have a huge body of evidence on what to do in a complication. We have never researched, really have never researched, how normal birth happens. What is the relationship of the woman's behavior? We are mammals. We have an endocrine system. We relate to the sun and the moon and our menstrual cycles and all of this. I know that there are more premature births, for example, during a full moon, because our tides and our menstrual cycles are all linked. We've got to record that. We haven't asked that question properly. And we are now pushing women in, while we mean well, but as Nick said, we've messed up. Our rate of cesarean sections in some countries is 70 to 80%. That is totally disrupting our normal oxytocin levels, the love drug, sex, breastfeeding, feeling good, patting a dog. That all disappears out the window as soon as you walk into a room with people holding forceps and all the rest of it. So we've done a good job on trying to solve some very, very difficult clinical problems. But what we're really fighting for now as a group of midwives, as a fantastic group of midwife-led research folks at the moment, is to really understand how our bodies work in harmony with nature and what actually promotes and sustains a positive birth. But we must always have on hand those really excellent doctors who know the research about what to do in emergencies. We have become unbalanced in our approach, and I've got a slide to show you later to explain that.
Thanks, Fran. That is so interesting to hear you say that. Obviously, you start to think of your own experience as well. But I think like the idea that there's a connection here to this bigger question of how we connect with nature and how we see ourselves, I guess, as humans, as part of the natural world. And that goes all the way to the very start of life and how we come into this world and the whole experience of that. I wanted to ask you about the SDG targets on midwifery. Could you talk to us a bit, and if you have some slides to show, or I think you also had a video you wanted to show about where we are 5 years on in relation to the targets on midwifery and childbirth.
Thanks. And I think if we could just start with that short video, Hala has it and she was going to put it up. And then I have a brief slide on the SDGs to show how interconnected everything is around women, newborn, sexual reproductive health rights. But this video brings together the issues that Nick's just talked about. It's where we need water for health, that it's a gender issue for women. Women collect water, women need water. And so it becomes a climate change issue. And if we just look at the facility that we've got, two facilities here, one in Liverpool and one in Uganda. And I'll be quiet now because I think every time I watch this, I pick something else up. So please enjoy this short video. It's made by WaterAid about midwifery, which I love, that connection. It's wonderful. I hope you enjoy it.
Gosh, that was such a powerful video. Thanks for sharing that with us, Fran. So
Well,
you want to tell us a little bit about SDGs and how where we're at the moment?
We can put the next slide up. Well, the first of, I've only got 3 slides, Hala, you could put that up. But I think with the film, for me, it shows so much the inequality, the poverty, what it is we're putting women through, how disconnected we've become from nature, that we treat women like this. Birth and death used to take place in people's homes. We would witness a birth, we would witness a death, we accepted it. And now we're so sanitized. And I get angry about things like Dara does. And when I watch programs on the television, particularly Hollywood and things, that's not what birth is really like. And I think for many women don't even know anymore what a normal birth is. They expect it to be very over medicalized. And we're now in this situation that we have 3 generations of women in many societies for the first time in our evolution that have never breastfed and cannot breastfeed their own children. That means they are utterly reliant on major companies to provide actually what is the most important and the first public health intervention, which is breastfeeding, and including in COVID, where breastfeeding gives way more immunity to babies than anything else at the moment, and where babies are being separated because it's thought that they might be infected by the mothers, but we have no evidence of that. So we've become so disconnected, and I think that film shows that, you know, this, even the lack of basics, water, it's the year of nurse midwife, 200 years since the birth of Florence Nightingale. A lot of the facilities that I work in, and I can see people on the participants list from Nepal and African countries, these facilities haven't changed or improved for 200 years because we feel that women's status is so low, that birth is something that women do, etc. So, you know, we've kind of lost touch with our priorities and how that relates to our planet and health and all of these issues. So I'll just go through this SDG slide, and I hope that the Hala, you're going to have to do this for me. But what I wanted to say was, that's it. I can't actually even read. I don't know if you can expand it. I'm trying to get rid of me so I can see the slide properly, because I can't remember. I'm sure I'm not the only one who can't remember every single SDG. So I was hoping to expand it if that's possible, Hala. But of course, good health and well-being is what we look at WHO. So maternal, newborn, child, sexual, reproductive health fits there. And now I really can't see all the other ones, but Hala, if you just take us through, it's also to do with clean water. It's also to do with gender. It's also to do with decent jobs. It's also to do with how we negotiate and work together in teams. So I'm afraid I can't, I should have had a copy of it in front of me. But all of these other SDGs interconnect and work together to support the good health of women and their newborns. And I think the SDGs for us in midwifery have been absolutely fabulous because we can see it is not just a clinical issue. It's not just about taking blood pressure, you know, giving oxytocin, you know, and then whatever happens next. So, you know, we cannot really improve the quality of care and you know, really achieve the SDGs if we don't address this as a multi-sectoral issue, all of which connects to our planetary health. I have to say we have made huge progress. There have been massive reductions in maternal mortality and newborn mortality, less so in stillbirths. That's still a really big problem. Much of that is down to family planning, which has been a really great global success. And I, for one, feel very strongly that we shouldn't point fingers at countries who have bigger numbers of children. We know that if you live in India, well, if you live in the UK, you use up 4 times the resources per person of a person in India. And if you live in the US, you use 10 times the resources. So the fact that people in India may have more children doesn't mean that they're using up more resources of our planet. You know, we are using up at least 4 times the number of the average person in India just by being in the UK and living in houses like this. So anyway, so that's all part of the successes that we've had. And this is just part of our challenge. And if you look at this photograph, on the left, obviously there's a cesarean section going on. And on the right is a photograph taken very recently in a country in Asia. And it's quite normal. So we don't know, I hope that the photograph on the left is a woman that needs a cesarean section to save her life or to save her baby's life, when we know that the 70 and 80% cesarean sections going on in hospitals, we know it's about an incentive. There are perverse incentives that pay hospitals more to do a cesarean section than to care for a woman in a normal birth. So we've seen this rapid rise in it, and it's become almost expected. Certainly in Brazil, women expect a cesarean. It's sort of just sold to them as the best option for their body, but it isn't. We have a cohort of children coming out of Australia, hundreds of thousands of them, and we're finding wherever there's been over-intervention, it has lifelong effects on these children's learning abilities. And we're beginning to really ask these different questions about what is going on. We haven't really researched what is the lifelong impact of an unnecessary intervention compared to a normal birth. And we're really just beginning to start to ask those questions. If you look at the woman on the slide on the right, I don't really know what's happening to her. Nobody does. Nobody's with her. It's filthy. It's insanitary. It's a human rights abuse that in 2020, she's in a place like that we call a health facility. So it becomes something, and I think every midwife, the midwives I work with, you know, we're passionate about it. We're angry like Dara about it, like people are about climate change. This should not be happening. And I think we've meant well, but you know, as Nick's gone, we've lost the plot. You know, this isn't right. This isn't what we should be doing. And Hala, if you can press the slide, there should be a quote at the top from Margaret Crook. And this is that globally for childbirth now, and not just the birth, but for antenatal childbirth, postnatal, sexual reproductive health, there's often too much too soon, the slide on the left, or too little too late. And the really, really big issue at the moment is that we have, even before the SDGs and the MDGs, felt that all women should get quality of care in a facility, and we've really driven people to go to a facility. Home births have almost disappeared in many countries. I was lucky to have all of mine at home. But now in most facilities, poor quality of care is a bigger barrier to reducing mortality than insufficient access. It used to be that people couldn't get to a facility. Now they get there, and the reason for their death in that facility is this kind of quality of care. And we have created this, and we have not been asking the right questions, and we have not been speaking to women, and we have not been listening to midwives. It's been very, very medically driven, the whole process, and that has disconnected us to the realities of women's lives, of midwives' lives, most of whom, not all, but most of them are women. And we haven't been talking about their experience when they get into these facilities to be able to improve them in a way that attracts them to come. Many women now do not go to facilities because they're terrified of being treated either one of these ways. And that in itself increases mortality rates. So I always think to the people of Ireland, Belfast and the UK, midwifery is a really difficult job, but look at what we've got here. It's got to keep getting better. And I know it's particularly hard now during COVID. Look at what women are going through in other countries. It's absolutely appalling. So I'll stop on that one.
Thanks, Fran. I think that it really struck me, that quote at the top there, and I think it struck other people as well. This kind of thread that's running through what we're talking about this morning, like the lack of the imbalances and how that affects both extremes, you could say, of people on facing inequalities. Those of us in Ireland, in the Western world, with the over medicalisation and the disconnect to nature, and then on the other side, the sheer inequality, but also the dependency on a healthy planet to thrive and survive. Obviously, we all depend on a healthy planet, but how this disconnect manifests itself in different ways in different parts of the world, in different contexts. We'll definitely come back, and I'm sure there'll be many questions to you on this later on. I want to move on now to Suraj Yose. He has to tell me if I'm pronouncing his name correctly. Suraj, your research, we're going to talk now about migration. Your research focuses on health and immigration detention centres, addressing challenges faced by health systems due to differences in values and norms amongst migrants and healthcare providers, and knowledge translation strategies in migrant health. You are yourself, or you describe yourself as a migrant from India living in Sweden. Maybe we could start just by asking you how your own experience of migration and that of others you know has shaped how you understand this bigger issue.
Thanks a lot for the opportunity to be part of this conference, and thanks for the question, Lorna. I've had this question asked several times to me in Sweden, and often my quick answer is that, of course, it has affected me, but I don't know if it has affected me or not because I haven't had time to sit and think if it has affected me or not. And something often I reflect now after spending almost more than a decade in Sweden, that what a kind of opportunity, privilege I've had compared to maybe other people in other countries, but also same time compared to in migratory terms we call the host population or the native population. The difference and the privilege, and often one example I take is that in India, for example, it's the idea is always study, 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 get a job, start a family, work probably till you die, and probably you die earlier because of a lot of the consequences we had discussed so far. And here, when I look at the school system in Sweden, you get the option as children, you explore yourself, you get to play with mud right from the play school time. And then often after the high school, you take a break, you travel, you come back, you see options, you go to university, which is free of cost. In India, that's where people actually take bank loans to send kids to school. So just to get that opportunity, and that actually not I'm not talking about me as an individual, but giving that perspective sort of to see it from both sides, and actually as to look more into what we have rather than what we don't have. And I think that might sound a bit philosophical, but that is quite important in like what we have heard so far from Dara and Nick and others, sort of have to look what are the positives, how can we enhance that. And I think that's what I focus a bit more on. And also I have to say that I do not belong to the majority of the migrants what we see in the world. I would say I am more of a privileged type of migrant. But also often it's worthwhile to discuss because even in English, when we speak, we have two terms to refer to the same group of people. We call expats and we call migrants. Literally, both are people who travel across a country to earn a living. But often, expats are used to refer to people, usually from the Western world, usually white, go to countries with high income, to get high salary. But others are also doing the laboring migrants doing the same thing, but we are not referring to the same term. It's at all the discourse is also quite interesting.
Thanks, Suraj. I think that is a really interesting point. I'm a migrant myself. I'm from Scotland and I live in Ireland. But the migration covers such a broad group of people. And I know that that's the focus of your work has been on looking at different kinds of migration and the causes and effects. And I know that you have some slides to show us on the whole issue. So migration is under, you could say, under SDG 10, but like all the other topics we've been discussing, it is interconnected with so many of the other SDGs. So if you would like to show your slides, and we can talk a bit about these interconnections between migration and the other SDGs.
Yes, I will do it in a second. And I always already have to apologize for a bit because I'm an academician and my slides will look a bit academic, and that's part of the occupational hazard. So just bear with me. I would try to focus on both the challenges and the success, what we have so far. But before that, I would also like to sort of, I know I'm not allowed to do a poll, but just a quick question, answer to this question. Just type in the chat box. How big do you think migration is? How many migrants do we think exist in the world? Just type some numbers in the chat box. 1 million, 10 million, 100 million, less than that, more than that. Just type in the chat window. I see 5 millions, billions, 100 millions, and goes. Good. I have an idea, and I see that some people might have a relative right answer. Some people have a bit disconnected in a sense. So our world population is around 7.7 billion, and the red person there would be a migrant. That is 1 in 7 is a migrant. So what that means is that it's around 1 billion migrants. And this is the biggest challenge I think we have to sort of address, that to increase public awareness that this is not a small group that we are always discussing. It's a rather larger group, and it might seem to be a sort of a surprise number for a lot of people, but I can explain why it is like that. We have two kinds of migrants. We have international migrants, the one who cross the borders, and internal migrants, the ones who does not cross a border. They stay within the same country. And just to get that understanding and just to understand the sheer magnitude, because like Nick was saying, when we have data, you can see increasing and decreasing trends, but that kind of data has not been near, and I'll get back to that later. So I think the biggest challenge is just to get the understanding of it. This is a larger population. It just doesn't go to ignore, like 1 in every 7 you meet is a migrant, and you can't ignore that. And then when you go beyond the numbers, you have to also look into what are the types of migration or migrant groups. And you can look at various aspects. I'm just listing some of those. For example, the reason. We have two groups there, the forced migrants and the ones who are living voluntary. Forced migrants are the ones we usually see in the newspaper, at least in Europe and probably in the US as well. Refugees, asylum seekers, irregular migrants. Often it is wrongly referred to as illegal migrants, but irregular migrants is the proper term to use. And versus the voluntary ones, basically the ones moving for work, family, and study. Um, and then we also have the geographical distribution, which we saw in the previous slides. The ones move across a country, beyond the borders, and the ones who stay within the country. Then we also have the so-called duration element. Are you a temporary migrant? Are you a student coming here for 1 year of study, 2 years of study? Or are you a worker coming here for just 2 or 3 months of an year? Or are you a permanent? I have a bit difficulty in sort of defining what is permanent, but are you a permanent migrant, sort of looking for a long-term settlement here? And there are various examples for that. The reason why we need to know the groups or the reasons and other kinds of factors here is that because that has an impact on the health. For example, for obvious reasons, if you're a forced migrant, there is a higher risk of being exposed to trauma and other health hazards, including malnutrition and skin burns and a lot of other things. And also even we see like what happens in the Mediterranean, right? You lose your life. Geographical distribution, that's where the legal aspects comes in. Which country do you belong to? Are you a citizen of country X or Y? Or are you, in worst case scenarios, are you stateless, where you don't necessarily belong to a particular state? And the duration also makes a difference because then, for example, the actions you need to take for the health aspects might have to be focused, not might, have to be focused in a collaboration between the country of origin, where the migrant actually comes from, but also the receiving country. For example, labor migrants from former Soviet Union countries going to Russia to work and then go back. And there is evidence sort of showing that they might contract diseases in Russia, bring back to their families in the other former Soviet Union countries, and vice versa. So it's important to know the various types as well. To make things complicated, these categories are not mutually exclusive. I mean, you can have internal migrants who are temporary, or you can also internal migrants who are forced to leave within the same country due to war, violence, and persecution, and they are known as internally displaced people, persons, IDPs. But it's at least it's worthwhile to know that understanding there. Just to show you why it's important to know the differences or the terminologies, this is a box plot showing the death rate ratios. And we have three groups. I hope you can see my laser point. You have three groups: the residents who does not leave, who does not migrate; IDPs, internally displaced persons; the ones who move within the same country but are forced to move from the place they are born and brought up. They habitually live. And then we have refugees who have crossed the international border. So if you look at the dotted line, if you like a dark shaded line here, it means that you do not have any increased death rate or risk of dying. So if you look at the green one, you see the darker line is all towards the left side, that is less than 1. It means that you actually have a lesser risk of dying if you're a refugee. When compared to being an IDP, you're a higher risk of dying because it's more than 1. And compared to residents, you also have a higher risk. To put this in context, think it's a country, Syria or any other country, where there is a war. And often people try to run away from war. So these are the people actually running away, far away to another country. So the risk of you dying from war is less compared to the people who are displaced within the same country, still where there is a war going on. And usually this group who decided not to move are usually depending on one particular faction where the impact of war might be less. So even without looking at the graph, so next time when you see a newspaper article, next time when you read an article, just looking at the names of the groups of migrants that have been discussed, you can get a rather good idea on what is happening there, what might be the health impacts they might be facing. Now, this is also another picture showing the proportion of migrants as part of the total population in a country. The darker shade shows that there are more than 40% of migrants living in various countries. For example, if you take the Middle East, Oman and UAE, United Arab Emirates, in United Arab Emirates, the data shows that around 87% of the population living in that country are migrants. That's just a lot. And that also poses challenges for the health system. How do we address it? What are the legal barriers? Are there cultural barriers? Are there language barriers? And a lot of other things coming into play. Now, SDGs, briefly, just to mention, these are the 3 SDGs where migration is mentioned directly. The 8th one, it's about labor migration, promoting safe and secure working environment and the labor rights. The 10th one, it's actually talking about reducing inequalities and about facilitating safe and orderly migration. There is also another sub-goal in there talking about the remittances, the money that is being sent back home mainly by labor migrants. And the 17th one is actually talking about disaggregated data. Like you said before, the need for data where we can actually see what are the impacts on migration and migrants, but also how they contribute. Then we have 2 more goals where migration is not mentioned clearly, but it is implied there. For example, goal number 3 on health, there is a sub-goal on migration of health professionals. And this is quite interesting. For example, there is some, I don't remember the exact numbers, there is some statistics showing that I think it was in Ghana or Gambia, the number of physicians per 10,000 population is less than 1.8 or 0.5 or something like that. At the same time, the number of doctors who have been educated in Ghana, now living in the UK, is much more than that. That sort of shows a lot of difference in how this is being managed. And actually, now we know that both countries need to attain SDGs, but the resource available. Then also the 4th goal actually talks more about providing more scholarship to individuals in developing and less developed countries. So those are sort of goals that are directly or indirectly related to migration.
Thank you.
Yes, sir. Yes, Lorna, go ahead.
Suresh, we're going to have to stop in 2 minutes. If you just want to finish up, then we'll come back in questions.
Yeah, I just have one more slide, so then we're done.
Fantastic.
So just to show that, like we discussed before, all of these goals are linked, but also like everyone else, as we heard before, we all are linked to each in one way or the other to all the 17 SDGs. I'm just showing the 5 as an example. Just one example, just show how migration is linked. One of the goals in the 3rd goal on health and well-being is end the epidemic of AIDS and other things. And I can show you one example. This is a graph from the European Center for Disease Control. And this shows the proportion of migrants among newly diagnosed HIV cases. So you can see that in Iceland over here, it's almost 80% or above among the newly diagnosed HIV cases in 2018 were of migrant origin. And it goes like this. And the EU, EEA, it's around 42% of all newly diagnosed cases are among migrants. This shows one picture, right? And this is what politicians, I'm not going to call in names, but like to promote this picture. And this is a success. We have this data because we have migrant status recorded here. But then we often don't discuss the fact post-migration acquisition of HIV. There are a lot of group of people who actually get HIV once they migrate to so-called Europe and other countries. And these are people coming from even high endemic HIV areas like sub-Saharan Africa. That is a lot more about how we are addressing and tackling it. So having data is a success, but not having detailed data is a challenge. That's all from my side, but just want to say this as well. I think this is, at least that's something I have to say. Migration is neither just a solution nor just a problem. Just a solution because countries see, oh, we have aging population, we need labor migrants. But then you're not necessarily seeing the long-term perspective. What happens then? Or just a problem. Oh, people are dying in the Mediterranean, or they're coming to my doorstep. That's a problem. We always have migrated as mankind, and that's going to exist. It has to be addressed across all 17 goals. Thank you, Lorna.
Thank you, Suresh. That very, very interesting and outlining for us, I guess, the complexity and the interconnectedness of migration as an issue which cuts across so many different sectors, and particularly the health sector. We've now come to the questions and answers session, which we have around 15-20 minutes for questions. And you can either put your questions in the chat box, or if you want to put your video on, we can find you and you can ask your question live. To do that, you have to raise your hand. If you go down to reactions at the bottom, there's a little button to raise your hand, and we will try and come to you. But there's already quite a few questions coming in the chat box. But before we go to questions, I want to give Amelia the opportunity to say a few words very briefly in response to what she has heard from the different panelists. So Amelia, if you're still there. If you want to respond very briefly, just with your thoughts on what the panelists have talked about.
Well, I'm so grateful to have had the opportunity to hear all of you. I think and now to comment as well. You all provided some very interesting insights, and I think I did not go into details into explaining all of this because I knew you would do better than myself. So I really, some of the things that struck me a little bit was like, first, we're discussing about, a lot of us are discussing about these man-made disasters like climate change, like forced migration, the damage that we're doing to the quality of healthcare of women as well by trying to put a lot of interventions in changing the way that we are as humans and how we must connect to nature. And I think that's also a reflection of the imbalance that we're having at the larger scale in our world, in our economies, in the way that we're planning our strategies, policies, and interventions. So I think what came back to me as well was something that Dada said about systems thinking. We need to change the system. We need to understand how our systems work. We need to understand also a bit better who are the most affected populations, and really take into consideration all of this in order to actually come up with transformative action, come up with those areas that will actually, if we put investments on, will help us drive the transformation that we want to see. And I saw that there was a question there, are we going to achieve the SDGs in the end? I mean, there's so many, and the bar we have set is really, really high. And I'd say, I don't know, but I hope so. And then we're doing our best, I think, with having set our bar so high and understanding better how we really need, how we could better achieve this. And we put together all our efforts and all our investments and really managing to like removing those perverse incentives, not only in climate, in the economy, in fossil fuel subsidies, in incentives in the hospital sector to treat patients in a more expensive way, and not allowing their old bodies to heal themselves. All of that, I think, if we think in the system in that way, then there is a possibility that we can achieve the SDGs.
Thank you. Thanks, Amelia. I'm going to go to Fran now. There's a question for you here, Fran, and it says, Fran, could you explain the connection between cultural barriers around the globe and the usage of various resources? Now, I'm not sure what kind of resources are referred to. Maybe that is Fran there? Oh, Fran might have had to.
Sorry, there we are. Sorry, sorry.
I don't know if the person who asked it is there, if they want to put their hand up and they can maybe explain a little bit what the usage of various resources might mean.
It's a complicated question, so it would be really helpful to, because of course there are huge cultural barriers and birth is a cultural issue. But I did have a slide, it's too late anyway, but on the relationship between gender, culture and quality. But if the person who asked the question wants to speak, that would be great.
They seem to be very shy, so maybe if you just answer it that way. I'm just trying to find the question so I can answer it properly, but there's certainly a relationship between culture, women, gender, and access to resources. So
we did a huge global listening project to midwives and women, which really hadn't happened before. And what we found out is that they had these three big barriers. The biggest one was their low social status. And historically, midwifery and nursing started off as cleaners, often seen as prostitutes. Even now, women in many countries can't work at night, going from one facility to the next, etc. So there's all this culture around women's status and stuff. Linked to that, of course, is the gender gap, if you like, of low pay that goes with the low status, and it's been seen as women's work. So then resources are not given. If I mentioned 80% of resources for research went on the complications and not onto actually how we sustain a healthy normal birth, healthy being the important thing. So all of these cultural issues around women's status interplay with the decisions by ministers of finance, etc., as to how many midwives are there or how much effort is put into making those facilities actually how they should be. So they are all incredibly intertwined. I hope that's answered it a bit. It's a complicated question.
Thanks, Fran. Yes, I think that answered it very well. Suraj, there's a question here for you in relation to how do we best provide universal healthcare to refugees and asylum seekers through existing health structures, whilst also responding to their unique needs? Is a whole of government approach needed? What countries or models of care can we learn from? It's a very good question.
It's also a tricky question. I can't name a country. Of course, I can name a country, but I probably would refrain from doing that. But it's an interesting and valid question. Like, what kind of approach do we need to respond to the health needs of migrants? My answer is that to not treat them differently on a bigger scale, because when I do give lectures, when I talk, I often ask the question, like, why do you think migrants' health is important? And sometimes when students does not have an answer, I ask the question, why do you think your health is important? It's the same reason. So then we don't necessarily need a differential treatment there, but the difference has to happen. For example, if I come to a country where I don't speak the language in day one, then the information needs to be accessible. That kind of information has to be there. And there are several countries who have good examples, for example, translations and cultural mediation and things like that. But I think the biggest thing is just to understand that in some cases they have specific needs, but in some cases you need and you don't need. And that's one of the things we are also looking into researchers. I mean, sometimes the healthcare system think, oh, they are so different. And you sometimes in certain countries, you stay there and you lecture the migrant on equality, gender equality, and all those values, and the important need for using contraception, because I assume you're from country X and I think you won't use it. But at the end, the migrants say, no, I actually came here for a contraception. So just that sometimes it goes to the other extreme, and sometimes it's to the other extreme where you don't ignore them at all. And just to link to what Fran said before, and showing the difference in what's happening in Uganda and Liverpool, and there is a lot of research showing that actually when women migrate from countries like Uganda or other countries, come to UK or Sweden, other countries, they still present a great proportion of the maternal mortality. So just because you come to a higher resource setting does not mean that your health is going to be well, as long as the health system does not understand. So of course, a whole of government approach is required, just like for everyone else. So that's the point I was saying. We don't have to treat them differently at a policy level, but there are special instances you need to give. I think the answer would be person-centered care. See the patient in front of you, treat them based on the needs they have.
Thanks. That's very, very comprehensive answer there. I'm just going to move back to Amelia for another question. And just a reminder to everyone, you can ask live questions. Don't be shy. You do need to raise your hand and you do need to have your video on to ask a live question, but please don't be shy about it. But meanwhile, Amelia, the question here is, given that most countries pre-COVID were not on track to meet all of the SDGs for 2030, how is it still achievable to meet these goals, given the setbacks that we're facing through the COVID crisis?
I think one of the things that the Secretary General had said in a recent speech is COVID has shown our capacity our enormous capacity of adaptation as humans and as civilizations, as societies. So it has shown that from one day to the other, when this is coupled with effective leadership and political commitment, that we can protect each other and change completely and radically the way that we live, the way that we recreate, the way that we eat, the way that we move. And therefore, I think that when there's adequate leadership and there's effective communication, as we've seen in countries like New Zealand, Germany, Denmark, Iceland, and Scotland, then we can definitely make the right decisions, prioritize those transformations that will help us accelerate progress. And these are around environment. These are around ensuring that everybody has access to essential public services, including health, social protection, justice, ending corruption, and ensuring that we use our economic resources better as well. That requires good systems thinking.
Thanks, Amelia. I'm going to come to you, Nick, listening to all of these different, I guess, dimensions of the SDGs, and just to, in a sense, get your reaction to the conversation at this point. What is really striking you in terms of the presentations that we've heard?
I mean, that's a broad question. Do we have 2 hours? Maybe to obfuscate with something that we probably all understand, implicit in the fact that we've shown up to this conference today. Everything is connected to everything everywhere, right? Like that's the clearest thing. It turns out that the environment is actually quite important. We just didn't realize until it started to change so quickly. It turns out that, you know, clean water, clean air, etc., is actually quite sort of essential to everything that we sort of do, not just our health, but all of those fundamental determinants. The thing I struggle with sometimes is understanding that and yet not letting it paralyze you. Because sometimes if you sit there and go, well, everything's connected to everything, then, oh God, well, what do I do when I wake up tomorrow morning? Because I have to do something, because there's some kind of moral imperative here, right? And so I think what I really like about this discussion and panel is there's an understanding that all of these different things are connected, but there's also an understanding that we all have a role, and that role is sort of different depending on your background, your expertise. Usually when someone says, what do I do given, you know, given the environment and human health are inextricably linked, how do I respond to that? The answer surely is you do the thing you're going to do. You do the thing that you will wake up tomorrow morning and do, and then wake up on Saturday morning and do it, Sunday morning and Monday morning. And, you know, you don't let it paralyze you. You just take one step and then a second step and then a third step.
Yeah.
How's that? That's some obfuscating reflection. Does that help?
No. I think that's a really, really good reflection, because I think the challenge even in hosting a panel like this is it's huge. It's a huge, complex area. So how do you kind of draw the threads of really what we're trying to talk about? The risk is that when we talk about the SDGs, in my opinion, we feel we're scratching the surface and we're never getting into. But I think what you say is really, really clear, that it's about continuing to do what we're doing in our whatever professional work is, but somehow allowing the breadth and the depth of the interdisciplinary experience here to penetrate that and to kind of to influence what we're doing and how we do it. So Niall has raised his hand. Which Niall is that has raised his hand to ask a question? Is that Niall Roach has raised his hand? So Niall, you want to ask a question?
I do, Lorna, yeah, thank you. I didn't want to intervene, but partly it's just to demonstrate how we can ask questions. So we go to the participants.
You're very brave being the first.
I'm very brave, thank you. Just to explain to everyone, in order to raise your hand, you need to go to the participants at the bottom of the toolbar, and you'll see the option to click raise your hand. So that's how we do it for future sessions. And I suppose my question really is for Nick, but also for Amelia and the other panelists as well. And looking at parallels, I know, between COVID-19 and climate change. I know tomorrow's our focus is on COVID-19, but Nick was at our conference in Galway in 2017 on climate change and health. And one of the things that he said is that we have the technology, but we don't have the political will. And there are massive kind of behavior change challenges for us as a population in terms of what we do to protect ourselves and protect our communities and our families. But how can we address kind of the behavior change issue in relation to politicians and our political system? If that could be addressed, that would be great. Thank you.
Thanks, Niall. Maybe you could come in on that first, Nick, and then maybe
a comprehensive answer in 15 seconds. It solves not just the climate crisis, but probably most other crises. Where that's fine. It's a good question. It's sort of the core question I suspect, regardless of the approach you come at, you are asking, right? There's certainly something in there about our ability to understand that, you know, whilst this is a macro political challenge, climate change, you know, responding to the Sustainable Development Goals, they are macro political challenges that really ultimately require, you know, governments at the scale of trillions, not millions, not, you know, hundreds of thousands to move. We are still individuals within that system, and so we still have agency within that system. The two things that I think we have learned with the Lancet Countdown's work: number one, we need to make sure that we get the message and the messenger right, and that message and messenger is going to shift depending on who your audience is. And so we spend a lot of our time grabbing nurses, grabbing physiotherapists, working with pharmacists, with doctors, trying to get them to communicate, hey, climate change is a health issue, but there are going to be other audiences that do a better, that need different messages and different messages. I think the other thing that we learn, and I am always so careful about, so cautious about, we must make sure we don't politicize these issues. One of the worst things that we have seen in Australia, where hopefully my accent reveals I'm from, and I think in the United States as well, is the response to climate change has become a political question. And the second you do that, we have lost, and you will not be able to break that, because definitionally it sits at 50% of the population. It must not become a political question. We must find a way to work through these and bring everyone in. This must be something that, you know, no one individual has to respond to, but everyone has to respond to.
Emilia, do you want to have a stab at that question as well?
Yeah, thank you for that question. It's a very, very, as they've said before, a tricky question as well. But I think as to complement a little bit what Nick discussed about the individual agency and, you know, how groups are trying to change and share the knowledge and build the capacities in individuals as well, that will turn into collective agency as well. And there was one thing as well that I want to remember that Dara said was, if we keep on trying, we can and we will win. And that means that even though this is an individual making an effort and trying to make change happen, that when that becomes a collective agency, we see the demands, like, you know, the different movements, Black Lives Matter, you see movements such as the one on climate change, etc. And those movements are changing the way in which politicians behave. This is not from one day to the other, but this will happen over time. And there are changes, again, you know, how we've seen plans being made, and a plan is a commitment. And although it's still not something we see and we can touch, slowly we will see these changes happen in our societies. So,
thanks, Emilia. I think it's quite interesting as you were talking about the alluding to the climate protests and the climate action. It's 1 year tomorrow, actually, since the global climate strike, which was led by Greta Thunberg and saw 7 million people on the streets. And I think one of the challenges that those young people have faced, like Dara, is the sense that the climate crisis has been overtaken by a health crisis in 2020, and that the focus of governments has shifted from climate onto the COVID crisis. So I think it's just a comment to say, I think a lot of the things that we're talking about this morning in terms of how we present climate change and like the health of the planet as a health issue just is so timely and so important, especially looking at the sustaining this sense of agency and I guess building the political momentum for further change. I'm going to finish with the questions there. And thanks to everybody who asked the questions, and sorry if we didn't manage to get to your question. I know that Emilia and Suraj will be available immediately after this session in the speakers' corners to take any further questions if people have them. But what I wanted to do is to give a minute to each of our presenters to give some final thoughts on what has been a really interesting and engaging panel discussion. I think it sets up some of the further conversations that you're going to have during the rest of this conference quite well. So to each of our speakers, maybe I'll start with Fran, if she's still there, to just give your final thoughts on this topic of the SDGs challenges and successes.
Big one. You know, we're moving in the right direction. There's a lot of energy for it. It is political. It's very difficult. Women's rights, sexual reproductive health has always been political. I think what I'm really enjoying is this Build Back Better discussion. And just my final link is we have big plans, and we almost had the funding we needed to link climate change with nursing and midwifery very directly in this year of the nurse midwife. Unfortunately, COVID has come along and shifted that sideways, but nurses and midwives are described as the most trusted health professionals. And I think the vision that wasn't there before COVID, before climate change, before these discussions, which are really helpful, is that if every single health worker on the planet was a campaigner for climate change, biodiversity, understanding health and the planet, it would have huge political resonance, you know, on who you know, the things that Nick said, who you vote for. We don't want it politicized, but when it becomes that way, you know, health workers are trusted, nurses and midwives the most. So that's where I see my hope. I think that will still happen, that work, but it was really to mobilize the entire global nursing midwifery community to fight for climate change on the understanding that it affects them, the people they care for, and everything that they do, as you saw in that film. So I think that's what I would say. Thanks, and thank you very much for all of this. Great discussions.
Thanks, Fran. Suraj, what are your final thoughts as we come to the end of the panel?
My final thought, I would rather define SDG as a move, an attempt to reduce inequalities. And that's basically, I think that sort of examples what we're discussing throughout. And I think, as we have discussed before, everything is interconnected, and that could probably paralyze you. But I think at the same time, we all have our agencies, and we have to work on that. But I think the main point, for example, because I was talking on migration, I would say that there are a lot of progress has been happening now. There have been global compacts on refugees, there have been global compact on safe migration. There are a lot of other things happening in the past 5 years. And and the problem is that then when get to know about more of the details, it becomes sort of a desperate picture. And I just want to record what Nick said. That should not make you more paranoid, or that should make you sad. That should actually give you the opposite, should give you the courage to push it forward. We have some idea on what's happening. Let's use this to move forward, because we can at least say that, see, in SDG, there is a point, there is a goal in that. Use that to the benefit.
Thanks, Suraj. Nick?
Sure. Final thoughts. A lot of it's been said, everything's connected to everything. We mustn't let that paralyze us. We have known about the links between health, climate change, and the Sustainable Development Goals, the environmental determinants of health. We have known about them for 30 years, for 40 years, for 50 years, for 60 years. We have spent, despite the impressive efforts of a few individuals, we spent far too long doing not enough about it. Just in the last 5 years, I think we've seen reasons for optimism. We've seen them in advances in air pollution. We've seen them in the phase out of coal-fired power, the end of the internal combustion engine, and that is incredibly important for health. In the next 12 months, we have a pretty unique opportunity. We have a pretty unique opportunity because the world is moving quickly, and big structures in the economy are moving in response to a global pandemic. Health is in its primacy, and the United Nations is hosting, the UNFCCC is hosting COP26 in the United Kingdom in Glasgow at the end of next year. We have 12 months to try to tie those things together. We have to make sure that the response to COVID, the response to one health crisis, does not lead to the worsening of another. They have to be mutually strengthening and enforcing.
Thanks, Nick. Emilia, what's your last word on this?
I think there's no silver bullet. That's what I wanted to say that as well. There's a lot that has to be done, and everything that we do can have trade-offs, but also co-benefits. And I think when it is come to prioritizing, is important that we know that there's this interconnectedness will result in that co-benefits and trade-offs. So it is not a simple task, but as long as we think in that way, I think we're going to make progress on the best that we can. And I think all of my colleague speakers here have given us wonderful information that we can use, and information is power, and how we can demand, and also how we can make decisions in our own different seats. Thank you.
Thanks, Emilia. So we've come to the end of our panel discussion, and I think you'll agree that it's been a fascinating tour de force, really, of a number of the different issues or SDGs, and almost kind of helped us to kind of break open what is the topic of our conference over the next 2 days. I have to make a confession that I'm a bit of an SDG skeptic, and I'm right from the start, I just wasn't convinced by these SDGs, having been very much involved in the MDGs. But I have to say the conversation this morning has really sparked my imagination, because the SDGs are so useful in this kind of context, in helping us to see the interconnections between all the different areas and how the different areas are interconnected. Obviously, they're also very important in increasing accountability of our governments and international institutions to make change, and to all the changes, positive changes that need to happen. So it's I feel quite hopeful at the end of this first session in seeing the amount of progress on some of the SDGs that has been made over the past 5 years. I'm very struck by the graph that Emilia showed, which was the U of change, and the need for a systems thinking in order to address that U shape of transformative change. And maybe I'll leave you just with a kind of thought that perhaps the historical moment we are living in now has forced us into that U, into that the U caused by the pandemic, caused by increasing climate breakdown. But the task of the SDGs and the work that this conference is helping to really bring to light is to help us to move back up into that the transformative part of the U curve. So on that note, I will hand over to Niall Roach, who is going to give you the instructions for lunch. Obviously, there is no lunch. And thank you very much.
Instructions for lunch. Thanks, Lorna. Yeah. Go make it yourself. Hello, everyone. As Lorna said, my name is Niall Roach. I'm actually an environmental health consultant. I'm a board member of the Irish Global Health Network and a member of the conference organising committee. And it's my job just to officially close this session. But before I do that, I have some final announcements. First up, I want to thank Lorna for fantastic moderation of the session. You really put a lot of effort into preparing for that, and it showed in what you were doing. I want to thank each of the speakers who we've been in touch with for quite a number of months to get this right. You've all given so generously of your time to contribute today. We know you have demanding jobs, and we're really very grateful that you took the time to participate in the session today. Thanks to you too, the audience. We still have 174 online for being present today and for your participation during the session. Your participation is not over, as we want to make sure that you take a moment to fill in the evaluation. I think it would have come up a few minutes ago in terms of your immediate reaction, but please take a moment to fill in the evaluation. And then also you have an opportunity to meet with two of our speakers after. So we've set up this thing called Speaker's Corner. So Emilia and Suresh are available for any follow-up questions you may have, or you may simply want to connect with them. There should be a link on the screen to the Speaker's Corner, and on that link you will find access to 2 breakout rooms, one with Emilia and one with Suresh. Lorna will join Amelia if there is a need to moderate, and I will join Surej. And these will operate for 10 minutes from 13:05 to 13:15. The next session begins at 13:30 hours Irish UK time, which is now 33 minutes from now, where the panel will be discussing the Sustainable Development Goals, 5 years on, ways forward. In the meantime, if you want to stay in this room, we will be playing a series of short videos on different global health topics. So grab your coffee, make your lunch, and keep tuning in. That concludes the session. I just want to again just thank everybody for your participation. And just as we have a spare minute, I just want to refer maybe to one of Fran's slides, because it's one of my favorite slides in relation to Sustainable Development Goals. For those of us working in global health, SDG 3 being at the middle, but of course, I see it as a plate, and of course we have all the other SDGs around that plate. So if you're focused on health, we can't forget about the other aspects of the plate, otherwise your food will fall off. Because everything is interconnected. And again, some people know me from teaching. Lorna mentioned a common thread throughout today was imbalances. And I often talk about in health that we get the balance right. And if any of you are a fan of 1980s music, you'll remember Depeche Mode, who are still on the go, and they have a song about getting the balance right. And I think for me, that will be one of my take-home messages from today's session. So I'll conclude it there, and thanks again to everybody.
Hello, my name is Savannah Dodd, and I'm the founder of the Photography Ethics. Hello, my name is Savannah Dodd, and I'm the founder of the Photography Ethics Center. This year, I had the honor of chairing the jury panel for the Global Health Photography Competition. This competition was organized by the Healthy People on a Healthy Planet online conference and the One World Festival, with the aim of stimulating debate, encouraging awareness, and promoting education about global health. When this photography competition was first conceived, we knew that we wanted it to be a little bit different from other photography competitions. Not only would it have a focus on global health, but we also decided that photographs would be judged according to their ethics as much as their aesthetics. In order to include consideration for the ethics of a photograph, we asked entrants to provide a context statement to describe how each photograph was taken. By asking for a context statement, we were asking how well the photographer understood the context they were in, beyond the strictly medical sense. We were asking the photographer to pause and reflect about their relationship to the people in their pictures. And we were asking them to be transparent about the processes through which their photographs were made. All of these things are elements or indicators of photography ethics. Ethics is central to every step in the photography process. Ethics helps us decide what we photograph, how we photograph it, how we edit that photograph, where we publish a photograph, and how we caption it. We make ethical decisions every time we take and share a photograph, whether or not we're aware of it. But judging another photographer's ethics is no easy feat, because ethics are subjective, contextual, and fluid. This means that different people will respond to ethical decisions in different ways, based on their life experience, personal judgments, and photographic vision. This also means that a person might make different ethical decisions depending on the context, because the appropriate response is not always the same in every situation. Instead of judging whether a photographer had good ethics or bad ethics, our jury panel looked for indicators of an ethical process. For example, we asked ourselves, does this photograph tell us something about the people pictured? Does this photograph reproduce stereotypes, or does it show us something new or different? Did the photographer spend time to develop a deeper understanding of the community where they were photographing? All of these questions were judged with equal weight to the question, is this photograph aesthetically pleasing? These questions are important because photographs are more than just pretty pictures. Photographs shape how we see the world, and when we take and share photographs, we're shaping how others see the world. This is an enormous responsibility. This is not meant to deter you from using photographs, but it is meant to encourage you to take a more critical approach to how you use photography in your global health work. Moreover, I hope that the photographs that have been shortlisted in this year's Global Health Photography Competition will inspire you to think about how you might ethically incorporate photographs into your global health work. The photographs submitted to this year's competition were assessed by 3 jurors, including myself. Joining me on the jury panel was Ben De La Cruz, an award-winning documentary video producer, multimedia journalist, and current senior visuals editor of multimedia coverage on global health and development at NPR. And Matt Riddle, a documentary photographer who was commissioned by the Royal Society of Public Health and the Health Foundation in 2018 to produce a photographic series called Healthy Lives, which explored environmental factors that restrict or enable people to live healthy lives in the UK. The 2 winning photographs and 6 shortlisted photographs will be on display online as part of the Healthy People on a Healthy Planet online conference and the One World Festival. Now, without further ado, I'd like to announce the 2 winners of this year's Global Health Photography Competition. In the professional category, I'd like to congratulate Bruna Amaral for her photograph titled Sarah Simon. In the non-professional category, I'd like to congratulate Natasha Douglas for her photograph titled Menstruation's Most Dangerous Challenge for Many Women in Nepal. Congratulations to our shortlisted photographers, Martha Tedese, Vunok Dong, Arpan Basu Chowdhury, and Pearl Gan. Thank you very much to everyone who submitted photographs for consideration. And finally, thank you to the Healthy People on a Healthy Planet conference team and to the One World Festival for hosting this competition. I would highly encourage you to go online to the conference website to read the context statement behind each of these winning photographs.
Quelle est vos noms?
Repeat. It's
And,
like, yeah. It's like it's
Good. So how do you pronounce this?
Père.
Père.
Mon père.
Mon
My
père.
my father.
Morgano life is quite difficult.
It's not good to stick sugar.
I know, but yes, if you want to work in night,
Yes.
then yes.
The most difficult is in terms of security. We've had quite a number of incidences. We are not able to even take a walk. Our only means of communication is through the radio, no phone network. It's either work or base. We don't have your social life. Can you bring more gauze from the store? Okay? Bring more gauze. Bring more gauze like that. Okay? Salam alaikum. Babu. So, what are you looking for? Okay, so strong contraction is last how long? I'm May Murithi, and I'm the maternal health manager. I'm part of the team that started the project in Munguno. She's really pushing. Let's see. Maybe the head is coming. Wumi, can she turn around? Husseina? Dagiga. We went out to the community, informed them about what exactly we are doing here, why we are here, and where they can find us. We are there 24/7. Contraction. It's coming, it's coming, it's coming. Wow, mashallah. We need to have the mama around for her support. Very good. Very good. Kinishi, alhamdulillah. Kinishi. Bismillah, alhamdulillah. Exactly at 11 for 12. No, taratib. Alhamdulillah. Fortunately, today we had a delivery. Usana Adamu, she's an 8-year-old lady. She's a first-time mother. And she comes from GSS, the official camp where the IDP camp is.
Ni ne uwar mijinta, ita matan yaro na ne. Dama tana awo a can, shine da nakudan nan ya faru, shine nace mata mu je asibiti gara ita shi da taimako za a yi mana haifuwa a gida ba daɗi.
The special thing about being pregnant in an IDP, the ladies are compromised in terms of the psychological stress, because if they are not mentally stable, it can affect their whole body system. Once you take care of the mental health, reassuring and explain to them the importance, they come. We advocate for them to have at least 5 antenatal clinics during their pregnancy.
Usaina ta samu lafiyanta, ta samu kanta a asibiti.
Barkanta.
Barkanta. Asibiti wajen Usaina.
Umi, salam alaikum. For me, the more motivation is the people here. It gives me a sense of hope and humbles me. Mashallah, he's kicking me. Hi, little one. 150. The things that we take for granted are not there here. You see how much people are able to withstand so much stress in terms of the security, in terms of also being internally displaced, nutrition-wise. For me as a midwife, we are with the mother, you're more with the mother, but also there's that good feeling that during the pregnancy you've been with her, you've been able to prevent the major illnesses and morbidity. And once you see that baby and the smile on the mother, it makes your heart, it just glows. You just feel good. It's wonderful.
Mi trabajo es agricultura. Café, maíz, frijol. Yo me llamo Límbano Galvez Zabaleta.
Yo me llamo Crisanta Roblero López. Tengo 54 años.
Pues estuviéramos tal vez con con más vida, por decirlo así, porque tuviéramos más vegetación, más naturaleza. Y ahorita sí está costando, pues.
Ahorita casi no levantamos cosecha de café, por lo mismo del arroyo. Cuando primero levantamos como 30 bultos, 40 bultos y ahorita no. Levantamos lo mucho que sale es como 4 a 5 bultos. Y es bajo, pues, porque de ahí ya no sale ya para los gastos.
We tried to come up with a way of connecting the DC hospitals with the consultants at Queen Elizabeth Central Hospital. So WhatsApp group was the idea that we came up with.
I think it's being very effective at that because it's kind of instant consultations. People with questions are getting feedback from a specialist almost immediately.
We post even the pictures and the consultants do see the pictures and they can advise to say, well, proceed to this side so that you are able to reach the problem.
You give feedback immediately, you say, you know, deal with it there, do this, do that, or, you know, do these investigations and call us or send the patient up. Or sometimes don't send the patient up.
We find it very useful because we notify them in advance so that they should get prepared.
You need to discuss the cases even before you refer them. They say, oh, well, Mr. Malunga, before you refer the patient, do A, B, C, D, E, because this patient has to arrive in Queens whilst in a safe condition.
It's pretty helpful in terms of giving them advice. For example, if it's something that they can do at the district hospital, at least you'll be able to give them advice on what they need to do for the patient before they refer, or at least as they refer.
When we send the patients, we get even feedback right away on the WhatsApp forum.
I love the feedback and even in the teaching itself. Because, you know, medicine is dynamic. Each and every day you need to learn.
We have got 10 DC hospitals, and in terms of membership, individuals, we have got 100 individuals, almost 100 individuals in the group. They have access to about 14 consultants. The good thing about the WhatsApp group is that once they post a case on the group, 1, 2 or more consultants will contribute on the case, which creates that access to many consultants at once.
We're not reaching only to one person, so you reach out to quite a number of clinicians. So as much as I may advise one person to prepare the patient in a certain way,
on a specific patient, I'm sure somebody else is also learning from the same group.
The best thing is that not only that we are given feedback, but also we are learning.
There was quite a big gap between us and them. But now the WhatsApp group, basically, we've come like a family. We can interact, we can communicate, and they're not afraid to ask for medical opinions, surgical opinions.
It's a no-cost thing. It just takes people's time. There's no money invested in it, so there's no reason for it not to continue.
Through Surge Africa, these are happening, and that's what Ministry of Health is supposed to do anyway, and the Central Hospital is supposed to do, and Surge Africa is just helping, coming in the right direction at the right time.
I don't know how I can describe that day. That day, I felt the world is over for me. I went to the hospital to register the pregnancy. They ordered me to do my routine tests. Later, the results came out. I was HIV positive. So I feel like I'm in a jail. Everything was tied up with me that day. Because some people think when you have HIV, it's a death sentence. They have sentenced you to death. If had it not been the intervention of PIH, maybe today I will not sit here to talk. You see, I will not even know you guys. You see. And I believe there is hope. They encouraged me. They said all is not lost. There is still life with HIV. So I started taking my medication until I gave birth. I was living with the virus. I gave birth to them. My husband is negative, my children are negative, but I'm positive. So I become an hero. I say, so you can use me as an example, just take your medication. Because of the passion they showed me, the initial passion, the love, the care they showed me too, I don't want to keep it to myself. So that's motivate me. I decided to share it to my colleague. Because of PIH, I'm proud to say With a little salary, I've educated my child onto wide-scale level. I've already made a difference because as I am here today, I'm a counselor for them, the newly diagnosed patients. I'm a brighter example to them. I use myself as an example. The reason and the benefit of taking medication. I think I'm living that average life which every Sierra Leonean can proud of. Before when they diagnosed me, I think I don't have future. But today, I have future.
Hello, my name is Savannah Dodd, and I'm the founder of the photography